Well, it's certainly a better package than the PA catheter, and this is what I'm going to talk about. Thank you for the question. So here are my disclosures. They have not changed, and certainly I'm a member of the Medical Advisory Board of Propulsion. As in my previous talk, this is my email. You can find it in the material that you receive. If you want a copy of my lecture, please send me an email. I'll be happy to send you a copy of my lecture. So the PiCCO is a multi-parametric approach to advanced hemodynamic monitoring. We have already mentioned that the patient has a CVP and an arterial and a thermistor-tipped arterial catheter. And these are the parameters that the PiCCO gives us: preload and fluid responsiveness, cardiac output, and I add SCVO2 because I share Professor Vincent's view that they complement each other, extravascular lung water, and a bunch of derived variables. Let's talk first about the cardiac output. We talked a lot about the cardiac output and the limitations of the cardiac output. But sometimes, like in a case like that, when the SCVO2 is normal, when the CVP is within the normal range, what is called the normal range, but the patient is still hyperlactatemic, the cardiac output stands out as the abnormal variable that demands some treatment. We talked about continuous cardiac output. In this regard, I would like to say just one thing, and I take this recent paper that showed that the change in vascular tone doesn't affect so much the continuous cardiac output, but it is nice to recalibrate. Now, the recalibration in the PiCCO means something totally different than recalibration in cardiac output machine, because when you shoot a cardiac output, you get all these parameters. You get preload, cardiac output, and lung water. Therefore, the recalibration of the cardiac output is done automatically whenever you want to see or remeasure any of these parameters. What about preload and fluid responsiveness? I'll go fast over the things that we have already mentioned. We said that we can get from advanced analysis of the hemodilution, of the thermodilution curve, we can get intra-thoracic blood volume, we can get global end-diastolic volume, volumetric measures of preload. We already mentioned that they are better than the filling pressure. They can differentiate between responders and non-responders, better than filling pressures in pancreatitis and subarachnoid hemorrhage, better than the CVP when the intra-abdominal pressure is high. And then, of course, we have fluid responsiveness, and we said that preload and fluid responsiveness are not the same. And in the PiCCO, we have already a pulse pressure variation and stroke volume variation. That's the first monitor that incorporated these monitors. And then we have the lung water. And we heard yesterday evening from Greg Martin, we heard about the lung water. And here are some papers that all show the same thing. When the lung water is 20 ml per kilogram, is associated with about 80% mortality. This is another recent study coming from the Far East showing a difference in mortality when the lung water is above or below 10. And here is a work of Charlie Phillips that was mentioned yesterday. And it is interesting not just because it shows that patients with higher lung water have lower survival, but because of the association and the correlation of lung water and the dead space. Because those people that think that, or they say that extravascular lung water is inaccurate because of microemboli, and that the dilution, the indicator, the cold indicator, doesn't reach vast areas in the lung. Actually, you should get an inverse relationship between dead space and extravascular lung water, and this is not the case. We have validated the extravascular lung water against gravimetric. This is work that we've done in dogs, and you can see whether it's a non-cardiogenic or cardiogenic pulmonary edema. It correlates nicely with gravimetric measurement of lung water, which is the gold standard. So imagine yourself doing a morning round, and rather than looking at the x-ray, you have a number. This patient had 20 ml per kilogram, and following something probably good that you did to him, now 24 hours is 10. Or look at this patient. This is severe ARDS. We were jetting her, we wanted the nitrous oxide, prone, whatever, but lung water was just fine. That's incompatible with ARDS. We talked yesterday whether there are ARDS patients that have normal lung water, but this is an example, and here it was pleural fluid. The power of the PiCCO. Here is a patient, head injury, severe ARDS, septic shock. He's hypotensive, he's tachycardic, the CVP is 5, severe respiratory failure, PO2 over FiO2 of 80 on PEEP of 16. Would you give him fluids? You must say yes. It's a classic hypovolemia, hypotension, tachycardia, low CVP. Just one thing you have to ask yourself. What is the price that the patient is going to pay if you're wrong? And it is in these patients that it's important to use advanced hemodynamic monitoring. They cannot pay the price of our mistake. Because this patient has a high cardiac output. He has a low SVR, obviously. He is hypervolemic. He has a high intrathoracic blood volume. And of course, he has a very high lung water. And what you need to do to this patient is to raise his blood pressure with noradrenaline and diuresis. If you're going to give him fluids, you are doing something bad. Take this patient, for example. Patient with chronic heart failure, and we have a lot of patients that come to the hospital already having chronic heart failure, sepsis, respiratory failure, hemodynamic instability. Cardiac output is low. The intrathoracic blood volume is low, lung water is high, stroke volume variation is high, is fluid responsive. This is what I call a classic therapeutic conflict, heart-lung conflict. What do you do? So, of course, here we decide that it's the cardiovascular system that is more important, and we give him fluid. And look at the lung water. They don't change. This is the cumulative fluid balance of this patient, and the lung water doesn't change. It's great to see that. And if you don't have lung water, you cannot actually be sure that it is safe to give fluids to this patient who is in pulmonary edema. But this is true up to a certain point. From a certain point and on, you can see that the lung water took a jump, and this is when we stop fluid loading. Let's look at this patient. This patient developed fulminant pulmonary edema during surgery, total hip replacement. He received blood, and this is in the post-anesthesia care unit. He has a low cardiac index. His ITBV is on the low side. Stroke volume variation 22 is fluid responsive in pulmonary edema, fluid coming out of the endotracheal tube, and of course very high lung water. Now let's play a little bit with the algorithm that the company is giving, and let's look at that. So we have here a cardiac output that is low, ITBV that low, extravascular lung water that is high. What does the algorithm say? Fluid cautiously and catecholamine. Well, we gave him fluids, and we gave him too much. Look at the intrathoracic blood volume. Really, we gave him too much. Now we are moving to the other side of the algorithm. Now we have a high cardiac output. We have a high global end-diastolic volume, high extravascular lung water, diuresis. Well, in this case, we just stop fluid loading and look at post-operative day 1 and 2. Everything is normalizing. Flash pulmonary edema, probably TRALI, high permeability pulmonary edema. We mentioned yesterday the relationship of extravascular lung water to intrathoracic blood volume as a measure of lung permeability, and here it was very high, and indeed the total protein ratio of the pulmonary edema fluid and the plasma was 1. So that is very high pulmonary edema. A word about the SCVO2. Here is a patient, and she is, as you can see, very sick, okay? She's very hypoxemic. Look at the arterial oxygenation, 86. You would assume that her SCVO2 would be low, right? Because arterial hypoxemia is one of the reasons for a low SCVO2. But look at SCVO2 as 80. Have we achieved the initial resuscitation goal? It's more than 70. Should be happy. As Jean-Louis said, well, what can you do in the patient that SCVO2 is more than 80? But I think this is where the challenge is. Okay, so here is the hemodynamic variable. Cardiac index, 2.7, low interthoracic blood volume, high lung water. Here we see the indocyanine green plasma disappearance rate, which is a measure of splanchnic perfusion, which is very low and shows that really this patient is still in shock, hypoperfused bowel, and she has very low oxygen extraction. Of course, this is why the SCVO2 is high. Can we do something about it? So the patient is getting dobutamine, and look, cardiac output is going up. Saturation is going up because she's so unsaturated that just the increase in cardiac output causes increase in saturation, and eventually the lung water goes down. So when the SCVO2 is high, that doesn't mean that you should do nothing, but maybe these patients need more advanced hemodynamic monitoring to know what better, what can we do for them. Okay, the power of the PiCCO. This is the PiCCO study. 206 patients and about 300, more than 300 physicians were given questionnaires, and they were asked to predict advanced hemodynamic parameters. This is the profile or the reasons why the PiCCO were put in: unclear fluid status, sepsis, respiratory failure, cardiogenic shock, renal failure. I showed this to you yesterday. We are very bad at predicting hemodynamic variables, advanced hemodynamic variables, just by clinical observation and by conventional monitoring alone. But look at this. Each of the participants had to say, what is it going to do? What is his therapeutic plan? Is it going to give fluids, red blood cells, inotrope, vasoconstrictors, etc., without the PiCCO data? And then he was shown the PiCCO data. A third changed their fluid decisions. Third. Fifth or more changed their decisions about inotrope and about vasoconstrictors, and you can see about diuretics. So it does have a tremendous impact on management. Well, algorithms. Well, here is something I showed you already, patient in subarachnoid hemorrhage. This is the treatment goals of this Japanese group, a very large group of patients with subarachnoid hemorrhage. And you can see the cardiac index, the GEDV, and the extravascular lung water are targeted. And what I showed you that indeed when at the beginning, the cardiac output can be very high, but this is very misleading because the patients are hypovolemic, and actually during their stay, they get more fluid, the cardiac output goes down, and they normalize. Cardiac surgery coming from Alvin Getz and Daniel Reuter in Hamburg. This is the algorithm that they used. And interestingly, they start with the GEDV. They said, before we do anything, we want to exclude hypovolemia in patients undergoing heart surgery. And the results were that the patients that were treated by this algorithm received less norepinephrine and less epinephrine. Another algorithm that was used also in cardiac patient by Professor Kirov, and the PiCCO-based algorithm patient received more dobutamine and more colloids and had a shorter hospital length of stay after OPCAP. What about ARDS? Because this is a very well-known but old study that showed that when you target extravascular lung water as treatment, you get better results than when you manage the patient with a PA catheter. This is an ongoing study right now. It's called the HEAL study. It's run by Charlie Phillips in Oregon. And I want just to make one point. When the lung water is high, and this has to do with therapeutic conflict, when the lung water is high and the mean arterial pressure is okay, and the patient is off vasopressors, but you have a low global end-diastolic volume, that is by volumetric parameter, the patient is hypovolemic, you do not correct that. You do not normalize preload in a high, if you don't have a good reason to do it, in a patient with high extravascular lung water. And as he said, this protocol allows aggressive diuresis of excess preload even during periods of shock, something not done in the FACT trial. This is accomplished by better identifying preload state using superior metrics of preload cardiovascular status, and you see the parameters. And this is just an example of a patient, and you can see in red the cumulative fluid status, and you can see over 10 days with a very aggressive diuresis and keeping a negative fluid balance that the lung water goes down very nicely. So how should the PiCCO be used? The first thing, is there a problem? Identify the problem, because many of our patients have more than one problem. Which seem to be the more critical? See, this is my problem with algorithm, because not all algorithms are good for all patients. So what seems to be the most critical problem? Is there a therapeutic conflict between, the two systems? And this is, I think, very important that we should all, I think, also transmit this to our students. Out of your potential therapeutic options, which decision will cause most or least damage in case of error? This is part of the decision process. Make your decision, follow results, and go back and start from the beginning. So when do I use the PiCCO? Major surgery in a patient with congestive heart failure, sepsis, ARDS, pulmonary edema, therapeutic conflict that we mentioned, expected hemodynamic instability, but above all, when the patient cannot afford to pay the price of my mistake. So in conclusion, critically ill patients do often have complex hemodynamics, may often present us with heart, lung, and other therapeutic conflicts, since, as we said before, individual parameters have limitations and confounding factors. A multi-parametric hemodynamic approach that includes lung water reduces the chance of erroneous critical decision, and I thank you for your attention.